Our discussion today will center around a very good patient of mine, a very good friend of mine, who almost paid the ultimate price for ignoring the symptoms of cardiac disease. This gentleman, who is now 53 years of age, had a heart attack at the age of 31 whilst he was in Guyana. At that time, he was admitted to the hospital with the chest pains, fever, and chills, and the diagnosis was made that he was having malaria. However, ultimately, the EKG showed that there was evidence of cardiac changes, and a physician in Guyana made a diagnosis that he possibly had a cardiac event. Nothing was ascertained at that time. My good friend continued a normal existence, unaware that his risk factors of diabetes, hypertension, and high cholesterol, with a very strong family history of heart disease in his father, much less so in his mother, who had high cholesterol. My good friend continued a normal existence as a professional, working many hours and also having a very full life with no medication, but for some reason he started to take aspirin. His chest pains never recurred, and then migrated to the United States about 10 years after. At the age of 45, had a cardiac evaluation done and was told that he had advanced heart disease and needed to have a coronary artery bypass graft. At that time, it was made very, very clear to him that unless he controls his cholesterol, controls his marginal diabetes and hypertension, mild hypertension, he would be at increased risk for coronary event. What had happened, if we can look at the mannequin, is that my good friend had a blockage in two of the main coronary arteries. This nice little organ is our heart, as we all know, with the superior vena cava that has the deoxygenated blood that goes into the right atrium, the inferior vena cava. It goes into the right atrium, then it goes into the lungs. It's pumped from the right atrium to the right ventricle, then it goes into the lungs which are on the side here, and then it becomes oxygenated and then returns back to the heart through the pulmonary veins with oxygenated blood, which then enters into the left atrium, and the left ventricle, which is the main chamber in this four-chamber structure that pumps this oxygenated blood into the aorta. The ascending aorta is here. And that blood now, when it's pumped, obviously goes up to the neck via the carotids, go across the heart by the thoracic aorta, through the thorax, into the abdomen to the abdominal aorta, before actually splitting up into the iliac veins that supplies the iliac arteries, and then finally supply the arterial blood supply to the leg through the femoral, the anterior tibial, and the peroneal. So the blood supply coming from this little organ itself is what is important for it. But this particular organ also needs its blood supply. And where does the blood supply for the heart comes from? The blood supply from the heart comes from the ascending aorta. So when you look at the blood supply, you have the right coronary artery that supplies this portion of the heart, also supplies the SA node, which controls the rhythm of the heart, and you also have marginal branches that supply the right ventricle. Remember, the heart is a pump, and if you're a pump, you need energy and you need oxygen. In this particular case, you can look at the tenuous blood supply, very, very small vessels that are actually supplying the heart itself. And when you look at the amount of muscle that has to be maintained in terms of the heart itself, that's something that's going 72 to 80 beats per minute every day. It's pumping 72 minutes and never stops. Definitely needs a good blood supply. Now, in the case of my good friend, his left, this is the right coronary artery that was completely blocked. The left coronary artery, which is here, that supplies the circumflex across here, that supplies the rest of the left ventricle posteriorly, and the left anterior descending, which is the main artery that supplies the left ventricle. In my good friend's case, at that time, he had a complete occlusion of the right coronary artery. He also had a total occlusion of the left anterior descending artery. What was functional for him was the left circumflex artery. However, what prevented him from dying from sudden death was he had numerous tributaries from these arteries that were from supplying blood distally. Just imagine how simplistic it is. If you have a blockage higher up into the coronary artery, you're not going to get a distal outflow. If you get a blockage distally, yes, you will get a proximal outflow, so the rest of the heart will be supplied. All of that is just to explain to you a simple phenomenon. What damages the coronary arteries is obviously the uncontrolled diabetes, the uncontrolled hypertension, the uncontrolled high cholesterol. Before, in a previous talk, we discussed with you what are the implications of trying to keep just the average artery, and this applies also to coronary artery. And we know coronary artery disease is the single largest killer in the United States, with 1.1 million Americans have a first or a second heart attack each year. What are statistics? 1.1 million of us will have a heart attack, a first or a second heart attack each year. And 1/3 of all of those heart attacks is fatal. For my good friend, he was happy to be in Guyana, have a heart attack, and still survive. Came to the United States, was told it was complete occlusion. Veins were harvested from the internal mammary, which is inside of the chest wall, and also from the leg itself. And he had a bypass done, which was successful. The bypass was done to obliterate the occlusion. A bypass is basically a method of just using the veins and turning them upside down and bypassing whichever is occluded. Remember, it's not the beauty of the system, it's the fact of maintaining the muscle of the heart. A lot of us will have stents, and a lot of us have had stents in the past, and the stents are meant to just prevent an occlusion. And they just bypass. It's a silastic tube that allows blood to flow past, but it's only useful when you can actually find that is outflow distally. If you have a blockage proximally that you can actually create a drainage, then that blood will now flow through the artery to connect here. But if everything is obliterated, there is no need for a stent. So a lot of us are banking on the fact that stent will save us. No. Stent will save you if there's only a minimal proximal occlusion or minimal distal occlusion. For all intents and purposes, and I will carry on this discussion in our next talk, is for us to control the high cholesterol, control the diabetes, to prevent this from happening. The endothelial lining of the arteries themselves become so irritated by the fact of the high cholesterol, which now brings the LDL forming this plaque. Now the macrophages come in, the plaque ruptures, that basically includes the blood vessel itself, and even the muscles around it becomes hypertrophy. So instead of having a nice big lumen, we have this almost obliterated coronary artery. Imagine when it occurs in the big blood vessels, it is an issue. But also imagine what worse of an issue, especially for the coronary arteries, and also especially for those of the brain itself. That is where we get the maximum morbidity and mortality associated with stroke and heart attack. We will continue this discussion. Continuing our discussion on my good friend who had a coronary artery bypass graft, having had a heart attack, a coronary artery bypass graft at the age of 45, having had his first heart attack at the age of 31 due to uncontrolled diabetes, but not massively so, and mild hypertension, but the hyperlipidemia, the high cholesterol, which actually totally occluded his heart. The diagnosis was made after he had a heart attack in Guyana, but this took a while before it was made, so nothing could have been done about it. But he continued not to have symptoms. He developed collaterals around the heart that continued to supply the blood, and even though he led a very hectic lifestyle, he didn't have any other symptoms until about 10 years thereafter. And then he started to seek medical treatment in the United States, and at the age of 45 had his first coronary artery bypass graft when it was diagnosed that he had a total occlusion, and he could have had a sudden death. And how we usually describe this in our community as saying, oh, this man was in perfect health, he used to run, he looks nice and fat, he looks nice and good, he walks around, he has a normal life, and he died suddenly. In the United States, it's a lot more different. We have to address the issues as to why a young person dies, and if so, what measures were taken to prevent the death of that individual. In this young man, what he had was uncontrolled hypertension, diabetes, but not greatly so that we would get alarmed and say, oh, this is going to cause a cardiac event. Remember, at all times, when we think about hypertension, diabetes, high cholesterol, let's think about not the disease itself, but what are the end organ damage to it. And the main one for us is the heart, eyes, and the kidneys. But we're sticking to the heart today because this is the one it stops. This is the one with such a tenuous blood supply and so common in our community that we have probably the highest incidence, if anywhere in the United States, and I will even say of anywhere in the world, with the highest incidence of premature coronary artery disease in any single population. People of Indo-Caribbean descent. And I've seen alarming statistics that we do occupy the largest proportion of coronary care beds in a catchment area about 10 miles from the intersection Liberty and Lefferts. Of any hospital in this neighborhood, we occupy primarily, even though we do not account for that proportionate amount of population, we occupy a disproportionate amount of the coronary care beds. So it's important for us to realize it's not just a statistic, it's your life you're dealing with. So when you have these diagnoses, make sure you follow your doctor's advice, and you are the ultimate protectorate of your organs. We continue this discussion on the heart because my good friend had a coronary artery bypass graft and was doing well. But remember, the disease that was in the coronary arteries was also the same disease in the harvested vessels that was done for the bypass. So you bypass where the occlusion was. But here again, you need to continue, even though you had the bypass, you have another lease on life, because the bypass provides new blood, new oxygenated blood to a previously depleted heart. Now the heart will pump nicely. Your risk factors for getting a cardiac event is much decreased, but the same disease process that caused it in the first case still goes on. So it's so important for us to continue to take our medication and prevent it. Take our anti-lipid medications, control our high blood pressure, make sure our sugar is controlled, continue taking our aspirins every day. If a Plavix is indicated, we continue taking them. So whatever your doctor prescribed to prevent advanced from your coronary artery, the coronary artery disease from becoming more advanced. How much more advanced can you get from having a bypass graft? Well, my good friend continued his normal existence. For the first 5 or 6 years, he was scared. After that, he felt that the graft was there forever. He was warned that it's not there forever. Now, 4 years later, this was a couple days ago, he had a cardiac event. He started to have increasing shortness of breath. And how does it present itself? You're getting tiredness and fatigue. You walk a little while, you get shortness of breath, you get mild chest pain, but you do not get classic pressing chest pain on the chest wall itself. You do not get the classic description of the pain that radiates up to the neck, into the jaw itself, or radiates down the arm. Because remember, during the coronary artery bypass graft, you enter into the chest cavity, and all the nerve supplies to it are no longer there. So where the cardiac plexus supplies the nerve to the anterior was no longer there. And a lot of us think that cardiac symptoms always present in a classic fashion of retrosternal chest pain, pain over the sternum itself, that radiates up to the neck and radiates down the arm and sometimes radiates to the back. Yes, that's in a classic case. But the majority of diabetics would not, even because of the neuropathy, present like that. So chest pain is itself a good parameter. But increasing tiredness, increased tiredness on exertion, increased chest pain on exertion, increased shortness of breath, not being able to do the things that you were able to do before, are all the hallmarks for the index of suspicion to know that you are high risk. And how much higher risk can somebody be if you've already had a bypass graft done? Lo and behold, presented at the hospital, total occlusion of every single blood vessel that was even bypassed. Now he was facing a position where you had 30% of one vessel maintaining the entire heart itself and pumping away. He had numerous tributaries which saved him. An emergency surgery was done, but basically because of the instability of his cardiopulmonary system, based on the fact he's got such a minimal blood supply, such a tenuous blood supply to the heart muscles that if anything had gone wrong in surgery, whether or not he developed an arrhythmia that prevented the blood, he could have actually had a stroke, a massive stroke, from a thromboembolic phenomenon when the heart goes into an arrhythmia. More importantly, if he had remained under general anesthesia for a long time, then he's at increased risk for a cardiac event on the operating theater. So a new procedure that is now being pioneered was done on this individual. My reason for telling you this is that let us all be aware that when these diagnoses are made, it is not made in a vacuum to say, let's control the sugar, the pressure, and the cholesterol. It is made for us to prevent end organ damage. And collectively, if we bring everything down to normal levels, increase our exercise, maintain our body weight, decrease and discontinue smoking and alcoholism, increase the amount of exercise and decrease your stress, you can actually prolong your existence and prevent end organ damage from your heart, your eyes, and your kidneys. Continue our discussion on my good friend with the coronary artery bypass graft that became totally occluded after 8 to 9 years, and I was faced with an increased risk of a massive cardiac event, and now totally unstable to have a normal procedure done, which is probably the open heart bypass again, and opening the sternum and opening the chest wall itself with a lot of scar tissue, which would take a very long time. So a new procedure, which was a robotic surgical procedure, was actually pioneered and was being done on this individual. The rationale behind it is that when you're faced with such an unstable patient, you have to minimize the time spent in the operating room and hopefully achieve a minimal result that will sustain life, continue to sustain life, and at the same time not expose the patient to increased cardiac risk by a prolonged surgery. When we imagine what the damages we do to our heart when the simple things like cholesterol, which have medications, tons of medications available to control it, the diabetes, which we can control so nicely with diet and exercise, and the high blood pressure by 1 or 2 medications per day. And to think about that, we could prolong our lives for many, many years and decrease the incidence of coronary artery disease, the heart attacks, the coronary events, and even the strokes that occur. And we can also decrease the damage, obviously, to our eyes and our kidneys. But we'll do that. We'll discuss that in another discussion. But when we ignore this little heart that sits in this chest wall, that supplies the entire body, your entire body depends on this little heart here, that supplies, that's sitting right in the chest wall here, that sends the blood supply to the brain, the blood supply to the arm, the blood supply to the chest wall, the blood supply to the abdomen, and the leg itself. We obviously know that we cannot be living without a heart that's pumping the amount of blood. When we get an echocardiogram, it tells us what the ejection fraction is, or the amount of blood that's being pumped out of the left ventricle. Because the left ventricle is the one that pumps the blood through the aorta, which is this big blood vessel that then sends it up to the neck itself through the carotid arteries, and also down the arms through the subclavian and the brachiocephalic arteries. Then posteriorly, it sends it down to the transverse aorta, then the thoracic aorta, and then the abdominal aorta, and then to the legs itself. Knowing fully well by doing an echocardiogram, and you see that the ejection fraction is decreasing, it means that the amount of blood that is being pumped by the left ventricle is not going to be enough to sustain it. We hope to have about 65%, and that is good enough to sustain normal activity. When you start approaching values of less than 50, then you start to worry. And how do you get those values? When we ignore our hypertension, diabetes, start to have decrease in blood supply, then we have damage to the cardiac muscle itself. And those are the things we face with. That's why it's so important to maintain the integrity of the blood supplies, the right coronary artery, the left anterior descending artery, the left circumflex artery. These are the ones that supply the heart with the blood. But you notice how narrow they are. So it's up to us not to try at all times to protect them. In my good friend's case, having had the bypass, now the bypass themselves became occluded because he ignored the fact that he had these disease processes and was never controlling them. Now, the minimally invasive procedure would have to be done through the chest wall itself. And this had to be done for people who are such great surgeons that sometimes you wonder if it were not for the medical care in the United States by some of these brilliant personnel, some of us would not be alive. And my friend is someone in question who should not have been alive had it not been for this procedure. They went through the posterior aspect of the heart itself and then did the bypass, harvesting grafts from his legs as it is. The whole thing about it, without us not wanting to know what the whole procedure was about, is to see the events that took place. A young man who probably was not aware, because Guyana and the rest of the Caribbean doesn't focus as much on diseases that affect us. But when you face in the United States of 1.1 million persons will have a heart attack, out of 275 to 300 million persons, 1.1 of your population, which literally is probably around the region of 3 to 4%, will have a heart attack, first or second. And out of those, 1/3 will die of the heart attack. It makes us more important. In this country, pay so much more attention to coronary artery disease. Not only is it a preventable disease and can actually be prevented totally or in an advanced stage of life, it costs an extraordinary amount of money. A lifetime supply of medication to control cholesterol, hypertension, and diabetes, no way pays for the amount of money that it costs the medical system to pay for coronary artery bypass graft or the care of a patient post-operative coronary artery bypass graft. Not only is it the increased morbidity and mortality, also a factor in the whole scenario is the decreased life expectancy once a disease is advanced, is the decrease of performance in the work environment, the home environment of this particular individual. And here again, it is important for us who have these diseases to understand, by taking care of them, visiting your doctors, whoever your doctors are, and making sure that on a monthly basis at least, you know what the status of your sugar, your cholesterol, and also your blood pressures on a daily basis. And it's not difficult to do. You can chart this on a daily basis. How difficult it is to get up in the morning, stick your finger and see what your fasting blood sugar is. Less than 110, you're happy. Control your diet as you actually want to. Discontinue all sweets. You're actually able to take the half the amount or quarter the amount of carbohydrates. You don't need a plate of rice to be satisfied. You don't need 2 rotis to be satisfied. You don't need half a loaf of hot bread to be satisfied. You have to eat commensurate on the amount of energy you're going to be expending. And most of us are in clerical jobs. Most of us, we get home, we sit on the couch. So we do not expend a lot of energy, and we keep putting on more and more weight, but not understanding that it's not the weight that is the problem. It's the damage that's doing to your coronary arteries. It's the damage that's doing to your renal arteries. It's the damage that's doing to your cerebral arteries. All of that will cause you, and also the retinal arteries as well. And that is what is going to cause the end organ damage to your eyes, your heart, your kidney, and the brain itself. So it's so important for us not to go life the way that my friend did, from having known about the history, family history, not controlling it, having been told he had a cardiac event, ignoring that as well, had a bypass graft, ignore that as well, and then continue with a minimal invasive procedure. The good outcome of this, my good friend is alive and well because the surgery was done by one of the most gifted surgeons. So my message here is that basically when you're faced with these issues, try the best you can to control it by diet, exercise, and medication, and get your families involved in your disease process. Continuing our discussion on common problems that I find in my family practice in Richmond Hill, Queens, and using this as a parameter to try and ascertain as best as I possibly can some of the things that are affecting our community. And when I see an increasing number of cases that are arising, it makes you wonder whether this is not just an isolated event, but seems to be a pattern of behavior. Many of the physicians who practice in the neighborhood share some of the same views that is an increasing amount of drug abuse starts up with marijuana and graduating up to things like heroin and cocaine, albeit not as large numbers as in some other communities. Early sexual activity, which is a big problem, and group sex activity as well. Cigarette smoking, massive impact on the teenagers, and alcoholism being accepted at an earlier and earlier age in our homes. Some of these patterns of behavior is extremely disturbing because once it starts, it is extremely difficult to eradicate. It becomes accepted, and sometimes the only method of dealing with it is for the child to be removed from that school and the group of friends, or the family to relocate to another state where they can pay more attention to the kids, or maybe the environment is better. Case in question, over the last week, I've been seeing a patient and her parents for over about 6 or 7 years. The mother came with me with a request. Doctor, said, Dr. Balde, I want you to examine my daughter, my teenage daughter, who is 15 years old, to see if she is sexually active. I was taken back by that particular request. For one, I felt that if I were the child, I would feel extremely alienated from my parent for having made a suggestion to a total stranger, albeit that stranger might have been the family physician for at least 6 or 7 years. The impact this creates on a child's mind is irreversible, because here you're asking for probably the most private of evaluation to be done in a very public setting. And it is not as if it's the first time this has been my experience. It has been asked time and time again. And I think if we address it as an issue, then maybe we can approach it differently. Rather than coming to the physician to say, Doctor, can you examine my daughter for premature sexual activity? Yes, there is a way of examining it to see whether or not the hymen is ruptured. But the hymen membrane, which protects the entrance into the vagina, can be ruptured from physical activity, can also be ruptured from foreign body's insertion at an earlier age when you're a toddler, etc. It can also be damaged from other reasons as well, other than sexual intercourse. Now, the extrapolation of this is if I found, just for instance, I did the physical examination, and I found that there was no hymen, do I conclude that this is sexual activity? And now, how then do I tell the mother that this is not really an indication that she was active? Now, if you find an intact hymen, what does that tell the mother? I told you so, I was not active. But the damage has already been done because you have a third party involved in this, albeit it's a doctor who's qualified to do an examination. But I think the approach should be, if you suspect your teenage child of having sexual activity, your teenage daughter of having sexual activity, is to probably ask the physician in the presence of your daughter, my daughter is not performing well in school. She is not performing as well as she was doing before. She has an altered level of behavior that seems not to be acceptable by me. I wonder whether or not she has a new group of friends. I wonder whether or not she's actually involved in any activities, albeit cigarette smoking, marijuana abuse, or premature sexual activity. But I would like her to be tested for sexually transmitted diseases and to see whether or not she's using them. In that case, she could have addressed the issue with her daughter prior to coming to the doctor. I am not happy with what you're doing, and I do suspect that you may be having sexual activity, but I would like to make sure you're not at risk for any sexually transmitted disease. Then take the discussion a bit further, and then at least you keep the respect of your child intact in front of a stranger. The issue with this is that at all times the bond between a child and a parent should always be kept intact, even at the expense of embarrassing that child, even at the expense of you feeling that your hard work has been vindicated Because you work so hard, you obeyed your parents, doesn't mean that your child will do the same for you. But remember, the more damage you do to the relationship with your child, it's a more long-lasting defect. Sometimes at that age, you bring on a rebellious behavior pattern. So now instead, as I found out in a couple of cases when I actually discussed these matters, instead of having one partner with sexual activity, now that the parent has brought it to the fore, then they go about having multiple sexual partners. So what we did as parents, we actually escalated what was an issue of suspicion to now a behavior that now puts your daughter at extreme risk for STDs, worst of all, HIV. Worst of all, infertility. Because remember, what we're looking at here is she was asked me to do an examination to see whether or not the hymen in the vagina is there. But look at the bigger issues. If you are active, you infect not only the vagina, you infect the uterus, you infect the fallopian tubes, and eventually if the fallopian tubes becomes blocked, you will be unable to get pregnant. Because if the egg is released from the ovary and cannot travel to the fallopian tube when she is ready for childbearing and actually embeds into the endometrial lining and then is fertilized, there's no way she's going to be able to get pregnant. So the more issues you're faced with, it's not only the trust factor with your child, it's not only the risk factor of sexually transmitted disease and HIV, it's your inability at a later date to carry on a further dialogue with your child. Because having gone to the extent of disapproving of their behavior and having a third party try and mediate that, yes, you are right as a parent that your child is sexually active, is not the right method of approach. Try and be on the side of your child and see what they're going through and the exposures to peer pressure that they're being faced with, especially in our community. And I'm addressing this as an issue because I'm not seeing isolated cases. I'm seeing this as being a pattern. The premature sexual activity, the premature sexual activity without protection, the premature group sexual activities, the issues to do with influence of alcoholism that makes behavior patterns change and makes people's behavior more lewd, the influx of cigarette smoking graduated to marijuana smoking and into better drugs, ecstasy, etc., and also in some cases intravenous heroin and also smoking cocaine, snorting cocaine. These are some of the issues we faced as a community, and sometimes we need to address it in a more private and public forum in order to address the bigger issues. Yesterday I saw a patient, 15 years of age, with a history of continuous abdominal pain and having to go to the bathroom to pass stool almost immediately after the belly pain. This is a 15-year-old who I'm seeing for the first time, who was seen by several physicians before. The parents are members of my practice. And the child was complaining of belly pain for almost about 4 to 5 years. Belly abdominal pain and pain over this region of the abdomen, which is below the diaphragm, involving the liver, the large bowel, the small bowel. When we look at it in a diagrammatic method, this is the abdomen we're faced with. So abdominal pain in any person, whether it be a child or an adult, involves the liver, the gallbladder, the distal end of the esophagus, the stomach, the distal end of the stomach, the duodenum, the jejunum, the distal ileum, and the colon, the sigmoid colon, the ascending colon, the transverse colon, descending colon, the sigmoid colon, and the rectum. Any one of these can result in belly pain. The issue addressing abdominal pain in a child is possibly to look and see whether or not the frequency of these pains, how often do you get this pain? When does the pain come on? When the pain comes on, how long does it last for? Is it relieved by analgesics? Is it relieved by antacid? Is it worsened by some foods? What is associated with loss of appetite? Is it associated with increased looseness of bowels? So many questions you have to ask yourself, especially in a child. But also you have to look at the other factor. Is there some sort of gain to be gotten from having belly pain prior to wanting to go to school? And as parents, sometimes you wonder whether or not your child develops belly pain conveniently to avoid going to school. So those are the things that primarily in the parent's mind was this child is probably malingering and obviously doesn't want to go to school based on these belly pains and complaining of, I've got the belly pain, I've got to go to the bathroom. Be that as it may, if it's the malingering aspect of it, you also need to make sure that you rule out what are some of the causes of abdominal pain associated with diarrhea. And if your child says they're having diarrhea, be free enough to say, can I look at the stool as well? Because you're also going to have to describe that stool. What is the color of the stool? Is it brown stool? Does it have any blood mixed in it? Does the stool dark and black suggestive of blood? Does it seem to have a texture that has a fibrous nature about it? That seems to suggest something like an inflammatory bowel disease. Is it watery stool? Is it foam stool? So some of the things that even if they have to go, you ask, can I look at it as well? And by right, it's important to look at it. So some of the ways you actually document when the pains are coming on, how long they last for. And at least when you're with the doctor, you're able to say quite easily, this is when my daughter gets the pain. This is when my son gets the pain. In this particular case, the parents were very clear in their minds when the child gets the pain. They had removed the element of malingering because the child was doing well in school and was obsessive about getting to school. Evaluation of this child showed a well-nourished child, obviously not dehydrated. So it means that the episodes of diarrhea were not that great. Pink, she was not anemic at the time. She didn't show any evidence of jaundice. Her thyroid gland looks normal. The rest of a physical examination showed a very normal bowel. No evidence of any enlargement or organomegaly associated with the liver, the spleen, or the kidneys. And there was no evidence of any distension or loss or discoloration of the skin itself, or any localized or generalized tenderness, or anything to suggest an infective process. So the overall physical examination was negative. But what I'm alluding to is the evaluation of abdominal pain does not lie with just looking at the belly and just palpating it around it. It follows with, let me get a blood test on your child, let me see what the blood levels are. Let me see, is your child sickle cell? Because you want to see what the strength of the blood is. If the strength of the blood is weak, you want to make sure the child does not have thalassemia or sickle cell, which can cause infarcts and cause episodic belly pain. You want to make sure there's no evidence of infection with an elevated white blood cell count. You want to look at electrolytes. Is there any evidence of premature kidney disease that can also cause generalized belly pain or episodic abdominal pain, also associated not with frequency of passing stools, but frequency of urination. You also want to examine the liver. You want to ask for a liver function test. If on your physical examination you found evidence of enlargement of the liver or the liver margin being depressed even further when you look at it, when you examine the abdomen, those are things that you look at. You're also going to be checking the rest of the stool for thyroid disease. Hyperthyroidism can cause rapid bowel movements as well. You're also going to look at the general health of the child. Can this child be a diabetic as well? So some of the things to start with includes a blood test, but it includes a good physical history from the child and the parent. Includes a very good physical examination, or a very complete physical examination from head to toe in the presence of the parents addressing the issues. And I'll address what has to be done after you've done a good physical, a good history and a physical. What else needs to be done in terms of investigation of abdominal pain in a teenager? Continuing our discussion on the teenager with belly pain, having gotten a very lengthy history from the parents and the child as well, and done a full physical examination from head to toe, including hair distribution, the degree of hydration or anemia, the presence of other associated lymph nodes in the head and the neck, the evidence of any discoloration or or diseases of the tongue itself, evidence of a thyroid gland, enlarged thyroid gland, the distribution of the child's development at that stage, and the examination of the abdomen, and also examination of the joints as well for evidence of things like juvenile rheumatoid arthritis, sickle cell anemia, presenting with belly pain from infarcts or from other collagen vascular diseases. The blood test was done and basically revealed quite a normal blood test. There was no evidence of anemia, sickle cell disease, thalassemia. There was no evidence of any renal disease or liver disease. There was no evidence of any abnormalities in the urine, with no evidence of protein in the urine to suggest early kidney disease or evidence of increased specific gravity. And the clinical examination was apparently normal, and so was the hematological examination. An X-ray was done at the abdomen, which showed normal air, gas, bowel pattern, which was also suggestive of a non-infective nature, and no evidence of obstruction within the abdomen. What was then requested was to have a CAT scan of the abdomen, and the CAT scan of the abdomen came back as essentially normal. The sonogram was done, which came back as normal, with no evidence of gallstones or kidney stones, even in a child, or no evidence of any fibroids, no evidence of any ectopic tumors within the abdomen, which can present with abdominal pain and diarrhea. In fact, one of the things that I've seen in the past is a child with belly pain and diarrhea to find evidence of chromophene cells close to the appendix, and it produces epinephrine. It makes that child feel very hyperactive, and at the same time, the minute they finish eating, they go straight to the bathroom. So that was the thought in my mind at the time. And I was told by the parents that the child was not seen by another doctor before. But then when I asked for any reports, then they produced a report that showed that the child did have evidence, an evaluation done, that showed she had evidence of argentaphan cells, which is what needs to be removed in order for this to be resolved. It just goes to show that even though it's a very rare thing in medicine to find that, it was found, but the parents did not want to accept this as being the cause. I haven't known the parents for years. I was able to insist to them, let's follow through with the surgeon and get the procedure done, and then evaluate her subsequent to the procedure by removal of the adrenaline secreting tumor. Then you can possibly see whether or not this stops. But the evaluation of a child, let's say for this case, it was a very rare cause. But let's say that's a regular patient that we see in our practice, definitely you go through those same scenarios of doing a minimal examination first, which is obviously a full physical, but definitely get the blood test done, get an X-ray done, get a sonogram done, and at least at that point in time, you can say, well, I don't see anything that I'm suggesting that could cause this. Now, if it persists, you get a CAT scan of the abdomen, and that was how this was found in the first place. It was done with contrast because it was not found normally. Now, we evaluate for other things that you can find in a CT scan of the abdomen that does not show on a sonogram because it's a much more definitive test. You also will get a stool test to see whether or not there's evidence of overcyst and parasite, because parasitic infection, especially for us who come from third world countries, is quite high. Also acquiring it from traveling, salmonella, shigellosis, etc., you can get quite commonly. And those will present with intractable belly pain, diarrhea, sometimes bloody diarrhea. Having done the stool test, you look for evidence of white blood cells. You also look for other esoteric diseases that can occur, shigellosis, etc., that can occur in even in a child in that particular age group. You also try and rule out things like collagen vascular disease, which can present with episodic belly pain, not so much with diarrhea, but definitely episodic belly pain. You can also have evidence of, find more commonly in adults, in young adults, inflammatory bowel disease, when you have evidence that the small bowel becomes inflamed with Crohn's disease. Not only does it become inflamed, it becomes narrow. It also produces levels of skip lesions in which the bowel itself can become obstructed. You also have chronic inflammatory bowel disease that can occur in children. Here again is that the index of suspicion to when you actually test the stool, but you also going to need to have a colonoscopy and endoscopy to do a biopsy to make sure that that diagnosis is a diagnosis made from a histopathological specimen and not from just symptoms, or not just from a clinical diagnosis, because it's not a clinical diagnosis, it's a clinical suspicion that can be confirmed, or that has to be confirmed, because the treatment, I do have quite a few patients, young women in my practice with Crohn's disease, who are on medication and who can swear to you that that's how they presented for years before they were actually diagnosed. So it's not uncommon for a young child, for a young person or young teenager, to have a colonoscopy done for the purpose only to diagnose or to rule out things like chronic inflammatory bowel disease, and labeling it like irritable bowel syndrome, which is a wastebasket for belly pain associated with some form of diarrhea or alteration of bowel habit, is unfair, because some of these disease processes can be treated, or at least excluding some things from the diet can also be extremely important. Lactose intolerance patients can also present with the same symptoms, but that's much more easily diagnosed. So belly pain in a teenager should not be ignored as only being too malingering. It should also be investigated properly with a systematic approach. Continuing on the topic of abdominal pain in teenagers and young adults, the number of times I've been actually asked by parents, the doctor, can you check my child to make sure they don't have an appendix? And I usually interpret that to mean, doctor, can you check my child to see whether or not they have an inflamed appendix? Because for all intents and purposes, for those of us who've never had abdominal surgery, we all have an appendix. The appendix is this vestigial structure that's at the distal end of the large bowel, the proximal end of the large bowel in the cecum. If you notice here where the small intestine joins the large intestine through that open, the ileocecal valve, the distal end of it is where you find this appendage, which used to be important in the past, but is now not so important. When you look at the appendix itself, it's that little vestigial structure. Does nothing for you. It can have argentified cells, as our previous patient, and present with diarrhea. But it has a little valve, a little opening here, where you can get impacted stone from the stool or hardened stone. And when this happens, what it does, it occludes the blood supply from the appendix. The appendicular artery no longer is able to sustain the blood supply to an occluded area. It becomes inflamed, it becomes swollen, then it becomes gangrenous. When it becomes gangrenous, then it is no longer viable and it has to be removed. That is the process of an appendectomy. But how does the patient present? Usually is a healthy person who presents with anorexia, I don't feel like eating, with vague periumbilical pain. The pain is never at the point where the appendix is. The pain is usually a periumbilical pain. The pain is around the central portion of the abdomen. Because when a part of the bowel becomes considered part of the midgut, so the pain from midgut radiates to the central portion of the abdomen, not to this area. So the patient will complain, I don't feel like eating, I feel unwell, I'm having periumbilical pain around the belly button. If this continues, then the pain radiates down to where the appendix is, and that's when the appendix is inflamed. The reason for the radiation of the pain is the inflamed appendix just irritates the peritoneal wall and now becomes localized to the area. At that point in time, any physician can diagnose an acute appendicitis. Just from the history, I feel unwell. I'm having a little bit of a fever, I feel anorexic. I have periumbilical pain, but now the pain seems to be shifting, and the pain seems to be shifting down to the right lower quadrant. That is assuming that that patient has the classic appendix in that position. But we all know that the appendix can vary in position depending on what is happening with the large bowel. So you can even have pain if the appendix is located over here. The bowel is everted on the other side, not transversus, but everted on the higher up. You can actually have it mimic gallbladder pain. But those are rare occasions. In fact, if you look at this diagram, there's so many places that you can actually have your appendix um, located that sometimes it is difficult to make the diagnosis if it's atypical, but very easy to make the diagnosis. These are all the different positions that you can find in your appendix. But basically, very, very easy to make the diagnosis. Periumbilical pain radiated to it. When you examine the abdomen, and a generalized examination of the abdomen will reveal diffuse tenderness around over the abdomen. But when you examine the appendix, which you can actually locate, the base of the appendix is located 1/3 of the way from the anterior superior iliac crest to the umbilicus. And you basically, at that point, is very tender, where the patient literally wants to jump up from the bed. You would obviously deal with an inflamed appendix, and the base of the appendix is inflamed, and there's where the diagnosis is made. Sometimes having made the diagnosis is not to give a painkiller, because you want the surgeon, when he examines the abdomen, to actually be able to palpate and ascertain for themselves what the degree of pain is. It's kind of sometimes considered cruel, but it's not cruel. It's to alleviate, to be able to make the proper diagnosis. Because suppose you give something for pain, then the surgeon comes along and not able to elucidate the same findings that you were able to do because the patient did not have any analgesic. What is done at that point in time, the person is admitted to the hospital, an intravenous line is set up. Sometimes rehydration helps tremendously with that person. And then evaluate the degree of the pain, whether the intensity and the severity of the pain is increasing. What you try and avoid at all costs is for an appendix to rupture because you are tardy in either getting to the physician or the surgeon is tardy in terms of making the diagnosis. And that appendix, which was gangrenous, now that appendix ruptures. So you just imagine if this appendix here becomes inflamed, it ruptures. What now happens is that stool from the large gut spreads throughout the peritoneal cavity. So the distal end of the appendix here, now you have stool in the appendix. Now you have a peritonitis. When you have a peritonitis, not only can you not make that small incision to just take the appendix out, with digital you can do it, take the appendix out and remove it at the base with a very small incision. If you have a ruptured appendix, you have to make an incisional scar throughout the abdomen, to the entire abdomen, through the umbilicus, and irrigate the bowel. Because in that case now, you're going to be left with an inflammation in the large bowel, which in itself will only lead to further problems in the future. And what are the major problems in the future? The major problem is having gone into an infected bowel, you are going to be left with scar tissue. Now you're faced with having gotten into the abdomen, you cut into the abdomen, not the small scar here, but you've cut into the abdomen, you've opened up the abdominal muscles, you've opened up the peritoneum to get to the appendix there, irrigating it, washing it out to get rid of as much stool as possible. But that in itself, because of the infective nature of it, not only have you done something that's going to be causing the patient more morbidity and mortality in the future, you've left a bigger scar in the abdomen, but the worst sequelae of it is adhesions, which are these small fibrous bands that form from the gut itself to the abdominal wall, the internal abdominal wall. And that itself can cause abdominal obstruction at any time. I've seen many patients who've had ruptured appendix present to the emergency room at all times with intestinal obstruction. And it's a very, very serious thing to live with. Because once you start to have intestinal obstruction, which means that the bowel becomes blocked at some point because you form these adhesions. When you form an adhesion, you occlude the passage of fluid from proximally to distally. And if this occurs on a regular basis, the patient complains of abdominal pain, bloating, not being able to pass gas at a later stage, and now starts to vomit. That means hospitalization, drip and suck if it doesn't settle. Drip and suck meaning putting a nasogastric tube to decompress the bowel and an intravenous line, and basically to rehydrate. If it doesn't settle, it means another operation. So every increasing operation will result in further scar tissue. So at all times in abdominal pain, you must be seen by your physician. If you have abdominal pain that starts in the periumbilical region, radiates to the to the right lower quadrant, definitely a first diagnosis has to be an inflamed appendix. And at all costs, have the evaluation done. Even if the appendix was not inflamed to the point of being edematous to rupture, remove it because it's not even needed. But it prevents another source of pathology in the future. Especially at a time like this when we are having so much snow and we're all faced with the perennial task of having to shovel snow early o'clock in the morning, etc. There are some risk factors associated with shoveling snow, and sometimes we have to be careful and as to how we approach the task of shoveling snow. Albeit it may be that at that time in the morning we need to get our car out, we need to at least create a passage to our driveway, or we need to clear the pave so at least we can create a common pedestrian path. But at least be careful at all times as you approach the task at hand. Sometimes we get out of the house early in the morning and immediately with shovel in hand start to shovel snow. And I've had a few patients in the past, and especially over the last week, in which a gentleman who was shoveling snow and hasn't done much physical work over the last couple of years did suffer a cardiac event as a result of it. So it's not uncommon for us to take the task into hand and forget the fact that it is manual work, even though it's in the cold, and it also takes an extra toll on the body that you just gotten out of bed, taking a shovel in hand and start to shovel. With chest pain presenting in that individual, because there was such a high index of suspicion as to his chest pain, it was not missed, and he did have a cardiac event, but the outcome of it was excellent because it was amenable to a minor intervention, which was a stent being implanted. The issue of that, be always aware when you started to shovel snow that if you do have a cardiac disease, be careful in terms of how much work you do and how elaborate is that work. With the cold, you can tend to push yourself excessively, and as you push yourself excessively, you increase the demand, the oxygen demand of the heart, and if your blood vessels are not good enough to cope with the increased demand, you can suffer a cardiac event. I've had myriads of patients that come in and say that they've been having increasing chest pain, but it's not only from the heart itself. When we look at that kind of chest pain or a typical chest pain, especially from manual physical activity, we have to look in terms of what is involved. In the case of this diagram, it could involve the chest wall itself. It could involve the pectoralis major muscle. It could also present with chest pain localized more so in the axillary, closer to the axilla, with the pectoralis minor being involved. All of these are muscles involved in shoveling snow. But there are also common muscles involved in any physical activity, whether we playing cricket, playing any ball sports, that we use the pectoralis muscle. And in case when we present with chest pain, especially in the younger person who we do not suspect to have cardiac disease, we're also thinking at the same time, does it involve the muscles of the chest wall? If so, is it the pectoralis major? Is it the pectoralis minor? Is it the serratus muscles involving intercostal muscles? More commonly, what I find is when patients localize that this pain is coming from an area involved in the costochondral junction, which is like the second costochondral junction of Trett's disease, basically they localize that area where the junction of the rib and the costal cartilage, they are especially painful when you move, any movement at all that involves moving the chest wall. In this skeleton, you can see that any movement, whether it be in inspiration, expiration, moving the hands itself, will involve movement of the entire rib cage. In that case, that will result in excruciating amount of pain. And I find much more commonly is, I find a younger patient coming in with costochondral pain. But when the older patient at risk for cardiac disease comes in with a similar kind of pain, you're faced with a diagnostic dilemma as to whether or not this chest pain is of cardiac origin, or is it a chest wall pain? If we say it's a chest wall pain, is it involving the rib cage itself? And primarily, it's going to be the junction between the cartilage and the bone. Is it involved in the junction between the sternum and the costal cartilage? And that can also be a source of pain. But in this kind of pain, it tends to be localized. Can we also get pleuritic chest pain, especially over the inside lining of the chest wall, as in this mannequin, and the outside lining of the lung itself? Yes, in terms of the outside lining of the lungs and the inside lining of the chest wall, the pleuritic space here can actually cause cicatrization after any infection at all involving the lungs itself, and bronchitis, whether viral or bacterial, is much more common with us these days. And anytime the patient decides to breathe, there's a sticking pain that comes on. In a patient who is healthy, it's not a difficult diagnosis to make, or at least you can have an EKG done. EKG comes back as normal, no evidence of ventricular tachycardia or any other abnormal heart rate and rhythm or STT wave changes suggestive of a cardiac event. We tend to treat the patient with at least an analgesic to get rid of the pain, maybe an injection to alleviate the pain, and see what happens with the pain itself, asking that person to rest it, maybe put a heating pad on it, take a non-steroidal anti-inflammatory on a regular basis, and evaluate within 48 hours. In the patient we suspect of having a cardiac disease, it is not just sufficient to do the EKG, but to see if there's any interval changes with the EKG, meaning has there been any changes with that EKG from the previous time you've seen that patient to now? Is there any other exacerbating factor that could actually be causing the chest pain? Is the blood pressure high? Is the patient undergoing an increased amount of stress? Were they involved in any physical activity prior to coming to your office? Is there resulting in any other changes, whether respiratory or otherwise, that could result in this chest pain? So at all times it's important to know your patients. It's also important to know the conditions under which they live and work in order at times to make sometimes the proper diagnosis, especially with atypical chest pain. Continuing our discussion on some of the common problems we're seeing these days with the heavy snow falling, the chest pains we discuss in some of the patients who present with atypical chest pain after not doing any physical activity and then started the shoveling snow. Also concomitant with that is the lower back pain that a lot of patients are presenting with. When we decide to start shoveling, especially excessive amount of snow for excessive periods of time, we can actually cause ourselves tremendous amount of harm in terms of the back pain produced. And a lot of times when we look at the simple anatomy of the back itself, we try and figure out what is actually causing that patient's back pain. Is it coming from the spinal cord itself? Let's, for instance, take the lumbosacral spine. Is it coming from the lumbar area? Or is it coming from the ligaments that actually support the spinal column itself? Or is it coming from the muscle and fascia that's associated with the lower back? What I find commonly is that patients would leave their homes very early in the morning and then start shoveling snow without even stretching or exercising, even for a minimal period of 2 to 3 minutes to try and relax the back before. Having come out of bed, you're faced with a fact of fluid retention in which the actual muscles of the back itself are much tighter than they should be. Minimum amount of stretching can actually alleviate the stress involved in the tensor fascial artery, which is the fascia that holds the muscles of the lower back to the backbone itself. But this in itself doesn't have a very good blood supply. And a lot of times when we just, without stretching or adequate physical activity, especially early in the mornings, what we tend to do is can cause tear within those muscles itself. When that happens, it causes an excruciating amount of pain over the lower part of the back. And that pain is diffuse over the lower part of the back, sometimes involving the iliac crest on both sides where the insertions are, or the entire lower back. That pain can also rise up to involve the entire cervical spine, the thoracic spine, but primarily it's always into the lumbar spine. When that pain tends to occur, then you're faced with the problem is the pain causing just localized tenderness over that area, or is pain radiating down the leg itself? If the pain is radiating down the leg itself, you know, we probably, from the excessive force that we're using, we can actually cause the disc that separates, the disc space that actually separates the spinal column, like here, to actually prolapse. When that prolapses, what it causes is the spinal cord, the nerve root that comes through that opening, that actually innervates. Let's say this is L1, 2, 3, 4, and 5. It actually can cause compression of that nerve root as it comes through. If that nerve root is being compressed, involving the fourth, fifth, and the first sacral vertebrae, it will cause numbness down the back of the leg, or most commonly called sciatica. So vigorous physical activity, whether it be at this time of the year when we get into physical activity just because of the necessity based on the accumulation of snow and having to do something about it, or the fact of physical activity during the summer when we play cricket and other ball sports, you basically have to be aware that you can damage your back quite easily, especially from excessive force or prolonged duration of activity involving the lower back. And here again, you're not faced with only the problems involving the bony structures of the back itself, the lumbar spine itself, but you also faced with the cartilaginous structures. You also faced with the interspinous ligaments that supports the back. These in themselves are very difficult to treat and can result in chronic pain. Sometimes in a case in which the nerve root is being compressed and causing intractable pain, loss of function of the limb, or numbness involved in the leg, as I had a patient over the last week who was having total numbness in the leg and asking, doctor, what can you do about the numbness? The only thing that can be done about the numbness is for decompression of the nerve root. If in fact there is no evidence of compression and the compression has been relieved, whether by therapy or by resting, then it takes time for that numbness to resolve. It's not going to be an automatic process. Here again, we need to try and avoid these injuries when they occur. The same thing happens with the lower back pain. If it involves the fascia itself, there's not a very good blood supply to this. So even by taking medications, the medications does not adequately muscular. Obviously, there's a liberal blood supply, and the medications will have a high enough level in order to give an analgesic effect. In the case in which it's a fascia, it's probably best for us to rest it, apply heat, at least take the analgesic, and at least try and prevent it. But the most important thing at this stage is to understand, if you're going to undertake physical activity for which you're not accustomed to, is to at least try and stretch first, at least get a warm-up period where you stretch the muscles of the lower back, whether forward, backward, to the sides, and at least stretch them enough that when you start to exercise by the constant movement of flexion and extension of the lower back, you do not cause injury either to the fascia, to the ligaments, to the muscles, or to the bones, or even the nerve roots involved. Two days ago, I saw a young 8-year-old child who was brought into the office screaming and crying because of headaches. The child was brought to my elder sister, who complained that her sister has been complaining of severe headaches and had to be brought out of school. And the child was crying uncontrollably with the headaches and would not stop crying. Obviously, the back of your mind is this is the worst headache the child has actually had. In fact, the whole episode of this child's pain, after sitting with her for about 5 minutes, was that she was shouted on in the cafeteria by another group of kids and felt embarrassed, and she felt so humiliated that she started to scream. And the only way she could get attention is by complaining that she has severe headaches, and the school just called the sister for her to take her home. Albeit this may be a situation in which the child was just being manipulative in order to get out of a bad situation. After a couple of minutes, the headaches were gone when she got something to drink, and basically she was told to be back into school. But this is not usually the general scenario that presents with severe headaches, especially headaches and dizziness that tends to occur in the older population. In a patient who presents with headaches First of all, the best scenario is this headache due from the fact of not eating, or hypoglycemic headaches, or tension headaches from too much going on, to the situation where you need to be in a position, is there a sign of increased intracranial pressure or something more sinister happening in the brain itself. In a case in which you have tension headaches or hypoglycemic headaches, you have to make inference on the fact of what is it that actually precipitates whether or not this is a first headache or a series of headaches, and at what time of the day it occurs. If so, is there any other precipitating cause of this headache? Because you're faced with headaches can be anything from very simple hypoglycemic headaches, tension headaches, to headaches that are due to migraine, which obviously cannot be treated the same way. So it's always important that you at least be able to get from the patient, when does a headache come on, how long does a headache last for, is there any mitigating factors that can actually increase or decrease the headaches, whether simple analgesic or resting, or whether there's a cyclic nature of the headaches, or whether or not there are any foods that bring on the headache. Also, you have to be faced, especially in the case of a child who presents with worse headaches that they've ever had, is to rule out things that can increase intracranial pressure, and the most likely cause of that is a tumor within the brain. In an adult, probably without insidious onset of a tumor within the brain, they will present with increasing headaches, but it was also associated with other symptoms of increased intracranial pressure. And those are the symptoms when the pressure within the brain tends to build up, because if you have a lesion growing in the brain, it compresses the brain, the brain is painless, but the meninges around the brain is where you get the pain from. But not only does that pain in itself cause excruciating pain over the area, it results in other symptoms of anorexia, not wanting to eat, of nauseousness, feeling as if I want to vomit, and also can be associated with the pressure is high enough, even slowing of the heart rate. But you don't want to wait until that happens. And what are some of the common causes? Over the last couple of days, I actually saw a woman who I didn't see for almost about 5 or 6 years. When we did diagnose that she had an intracerebral lesion, in fact, what she had was a berry aneurysm, which was an aneurysm involving the circle of Willis, or an area in the brain in which is supplied by a set of blood vessels, and she had a small aneurysm in one of those. The good thing about her is that they managed to find the aneurysm by doing an arteriogram, and the aneurysm was clipped before it could actually rupture. In cases where the aneurysm is, it can actually cause compression of the nerve that causes the eye to droop and ptosis in the eye over the cranial nerve that supplies the eyelid itself. So in a lot of cases you present with headaches, it's not only tumor, it's not only hypoglycemia, it's not only migraines, but headaches are come associated with dizziness, and you've ruled out causes of increased intracranial pressure. Some of the most common cause that we find in headaches is like sinus infection. If the infection is in the sinus gland, and the sinuses, and can actually affect the middle ear, because they all drain through the similar head and neck, ear, nose, and throat mechanisms. If an infection is involving the ear itself, it can affect that's the eardrum, that's the external ear, that's the auditory meatus, that's the eardrum, and then the ossicles through which the sound vibrates. But then we face with the semicircular canals and the cochlea, and we face with a balancing mechanism. When that becomes infected, we suffer with tinnitus. We feel a sense of losing our balance. We have dizziness. We feel as if the room is spinning. We're lying flat, and even though we're not moving, the room feels as if it's spinning. We feel unstable. We feel as if we're on a ship in which it keeps moving, and we're trying to keep our balance. Headaches, dizziness, and that sort of phenomena is actually to do with tinnitus, vertigo, based from middle ear infection. That is actually because this is the semicircular canals, and this is what controls the balancing mechanism. A very, very common disease process, sometimes easy to treat. Also, understandably, acoustic neuroma can also present with similar symptoms, but basically that's much rarer than we find in this phenomenon. In addition to that, patient who presents with fever, headaches, and obviously involving the frontal sinuses, the maxillary sinus, obviously those are the common things that we face with today, based on the fact that the cold weather, the change of weather, the fact of the increasing exposure to viral infections because of the close proximity to people in enclosed spaces. So that's a very common cause today or during the winter months, where the headaches, the dizziness, the deafness, the little bit of an imbalance, obviously to do with the sinuses and the middle ear itself. But also at the same time, we must also understand that headaches itself can also be caused by problems involving the eyes, especially in a hypertensive and diabetic population. So at all times, headaches and dizziness and imbalance should not be ignored as signs and symptoms for frivolous cause, because sometimes it could be sometimes it could be something a lot more sinister. Knee problems in family practice is a very common complaint. A lot of times our patient comes in complaining of pain and swelling involving the knee, acute onset of pain and swelling, decreased movement of the knee, evidence of excruciating pain over a particular portion of the knee. When we look at the skeleton in terms of evaluating knee pain, we can look in terms of see what are the structures that actually make up the knee, the bony structures, and we can see the distal end of the femur, where the condylar process, the medial and lateral epicondyle. We look at the patella or the kneecap. We look at the fibula, the little bone on the side of it, and the tibia, the main supporting bone that makes up the articular surface of the distal end of the femur and the proximal end of the tibia. So this is our knee joint itself. It's a hinge joint that can move in two planes, extension and flexion. But what keeps it able, what makes us able to keep the fluidity of motion is the articular cartilage that lines the distal end of the femur and the proximal end of the tibia. It is a medial meniscus and a lateral meniscus. The strength of the knee joint is made possible because of the lateral collateral ligament and the medial collateral ligament on that side, the anterior cruciate, the posterior cruciate ligament. In as much as it makes the joint move freely, it also is subject to injuries. And in evaluating a patient who presents with knee pain, is to take into consideration, if you imagine what your knee looks like, then it makes it so much simpler for the doctor to explain to you what is the injury related to your knee. So you know the knee joint is made up of this structure that spreads out here, that articulates with this one beneath, with a kneecap and ligaments on both sides. When we're faced with injuries to the knee, and here's again is the pictorial representation of what that skeletal structure is the distal end of the femur, the proximal end of the tibia, the lateral meniscus, the medial meniscus, which is what separates the cushion that separates it, that actually undergo changes. If we look at this portion of the tibia and looking down upon it, we see evidence of the lateral meniscus and the medial meniscus, the anterior cruciate ligament that is looking at this portion of the knee joint and looking at it inside the joint itself. And this is the portions that undergo tear. You can have a tear in the lateral meniscus or a tear in the medial meniscus. When you have a tear, as appears here in the posterior horn of the lateral meniscus, it just means the back of that semicircular cartilage that separates the bony structures. This is where we can actually get locking of the knee joint. The patient complains they're able to flex, but they can't extend it any longer. It gets locked in a particular position. It can also be associated with evidence of swelling, because when these ligaments, when these cartilage become damaged, they exude fluid. But the whole structure of the knee itself, anytime there's any damage, because of a simple fact, if you look at what this diagram looks like, you have evidence of the muscles around it. You have evidence of bursas, which actually maintains the fluidity. So in addition to the meniscus, you have evidence of these prepatellar bursas over the knee joint itself that can become inflamed as well. So the structure of the knee is a complex thing, but look at the bones themselves, look at the meniscus, look at the patella or the kneecap in front of it. But in addition to that, there's a muscle around the entire leg, plus evidence of these bursas which are sacs that's filled with fluid that can become inflamed. So when your doctor describes it as a bursitis involving the knee, it's evidence that these bursas around it, the prepatellar bursa, the anterior bursa, etc., these become inflamed and infected, or just inflamed and swollen and can give swelling to the knee. If the ligaments themselves become damaged, they also can cause evidence of the synovial fluid, or the fluid that keeps the joint itself moving without bone against bone. That in itself can exude into the space, and it can also cause pain. So pain and swelling in the knee joint can be as a result of bony injury, the cartilage or the meniscus in between, the evidence of the lateral medial collateral ligament, anterior and posterior cruciate ligament, or could also involve the bursa. When you see your physician and he actually evaluates that there's no evidence of infection, but just inflammation involving the knee, which gives rise to the pain and the swelling, and not evidence of infection, then you can treat it conservatively with non-steroidal anti-inflammatory with heat, whilst you try and evaluate in terms of getting an x-ray done to make sure there's no bony injury. But in addition to that is to rest it, put heat on it, and then evaluate as to the range of motion that's possible. Also, in addition, to make sure that this is not just a pain involving the bone, an isolated case, or this is generalized bone disease. In case of arthritis, which is involving the joint and the bone itself, but osteoarthritis involves only the bone itself. Osteoarthritis, as a result of previous injury, especially in athletes themselves, can cause the destruction of the joint itself. But that destruction is not only for the bones itself, it involves the ligaments, and it involves the meniscus itself. So knee injuries themselves, if you just imagine what your knee joint looks like, you can put it into perspective where the pain is coming from, which part of it, if it's on the medial, the lateral side of it, what is the structures that seem to be involved, if it's a locking arrangement, whether it's the anterior posterior cruciate ligament, if there's a laxity involved in the medial lateral collateral ligament, and can also make your diagnosis somewhat easier. In the event of us not being able to get some symptomatic relief from it, then an MRI is mandatory in order to show what's going on with the knee itself. That is the only study that can show us evidence of soft tissue injury and damage to soft tissue injury. In trying to answer the question, "Doctor, what is wrong with my shoulder? It is painful when I move it." Sometimes you are taken aback when this question is posed to you, and believe you me, it's posed to you on a daily basis, maybe 4 or 5 times a day in family practice, in a small to medium-sized practice as we have on Richmond Hill. A patient comes in, "Doctor, I'm having pain in the shoulder." And I sometimes think they expect you to say, well, the answer is oh, you have a bursitis, or you have a dislocated shoulder, or I think you have a tear in the coracoid ligament. If we try and examine the shoulder joint, then you can see why is it sometimes symptoms like pain in the shoulder joint, or decreased range of motion in the shoulder joint, or I'm unable to raise my arm above the level of the shoulder. I cannot even comb my hair because I'm unable to move the hand to the back of my head because the shoulder joint is stiff. Needs a little bit more of a careful analysis by the physician before coming to a diagnosis. If you look at the skeleton, this is the shoulder joint, as we all could recognize. The proximal end of the humerus, or this long bone, in which the head of the humerus fits into a ball and socket joint, the glenoid fossa, which is part of the scapula, or the breastbone at the back. So the movement of the shoulder joint through this is the head of the humerus articulating with the scapula as it moves upwards or downwards. It is a ball and socket joint because of a simple fact: you can flex, you can extend, you can abduct, you can adduct. These are range of motions that you can only get in a ball and socket joint. But the reason why you have a ball and socket joint and you have the movement that you have in this particular joint also gives it a disadvantage, that it's not going to be as strong as you want it to be. And it's the ligaments that hold it in place. But let's look at the bones themselves that actually articulate with the shoulder joint and close proximity to it. The proximal end of the humerus, the scapula, the glenoid fossa fits into, the spine of the scapula that joins with the clavicle or the collarbone, where the two of them form a fusion here, and the coracoid process, which is the anterior portion of the scapula. When you look at the shoulder joint itself, now seeing what the bones look like, you can see that when the capsule of the shoulder joint forms and fixes into the glenoid fossa, it is held together by the acromioclavicular ligament that holds the acromion process of the clavicle to the scapula. It's also held together by a acromial ligament and two conoid ligaments. Albeit to say it's a joint that's held together by numerous ligaments that's held to keep it in place. Also, in addition to that, you have the muscles that actually supply, that come from the back here, that basically supply the back itself, that actually is part of the shoulder joint itself. And a lot of times we're faced with issues to do, I'm unable to move the shoulder. When you look at the same shoulder joint itself here, this is the same proximal end of the humerus as it fits into it. That's the clavicle itself. The bursa that becomes inflamed most commonly is the subacromial bursa, as named before because it's below the acromial process and over the head of the humerus. And if it becomes inflamed, you're unable to move the shoulder joint in this arc. You can probably move it up to here. In order to get it above the shoulder, you need to incline and then get it above the shoulder. And what can cause, because this is one of the more common presenting complaints that we see in family practice, when a patient comes and says, "Doctor, I'm able to move the shoulder joint as I used to before." And it basically can be due to an inflammation involved in the subacromial process, but it also can be due to evidence of supraspinatus muscle tear, which occurs here, or even calcification involving the supraspinatus muscle. In addition to that, we can also face with issues that bursitis involving generalized bursitis involving the shoulder joint itself can produce inflammation of the bursas around the shoulder joint. So issues to do with pain involving the shoulder joint can be related to the bone itself, but very unlikely would you get osteoarthritic changes in a non-weight bearing joint. But you can get degenerative arthritis from the fact of overuse of the shoulder joint. You can also get pain of the shoulder joint involving the subacromial bursa or the supraspinatus ligament as the muscle inserts on this aspect of it. You could also have the deltoid muscles that can actually be inflamed that give shoulder pain. So pain involving the shoulder when presenting to the physician is not necessarily going to be due to just involving the joint itself, but you have to think about the muscles, you have to think about the ligaments around it, and then again you have to know what you can do. If you know the anatomy of the shoulder joint, then you can probably be able to advise the patient exactly what is the nature or what you think is probably the most common cause of that, and basically in terms of how to treat it. A lot of times in terms of the decreased movement of the shoulder joint, an injection into the subacromial bursa, an injection with a steroid can also give decreased swelling and increased range of motion. But sometimes you need to evaluate it properly and make a good decision as to what is causing the pain. If in the event of the patient being unresponsive to the injections or medication, then the next step is to, having got an X-ray and making sure that the bones themselves are intact, is to get an MRI to see what exactly is involved. Is it that the bony structure? Is it the cartilage around the head of the humerus, or in terms of the glenoid fossa? Is there a tear within the glenoid cavity? Is there evidence of a supraspinatus muscle tear, a subacromial bursitis, is it an infraspinatus muscle tear? And especially in young athletic males, the shoulder joint itself, especially if you're trying to get full recovery, the diagnosis has to be made whether or not it's muscular, whether or not it's cartilaginous, or whether or not it's bony. In all of us, as we try to maintain the use of our joints, especially the shoulder joints, since it's so important for us to be able to work and to function in our home environment, is to get a correct diagnosis and then a possible treatment that is going to alleviate the symptoms totally. some of the most common presenting complaints in family practice that I see in Richmond Hill are related to pains involving the elbow, the wrist, and the hand itself. If we try and look at the skeleton and relate what some of these are, we can see that the elbow joint is a hinge joint. It means it's capable of movement, flexion, and extension. But it's also capable of another motion called pronation, which is turning it this way, and supination, turning it outwards. The main bone of the elbow joint is obviously the main bones at the distal end of the humerus, with the condylar process, the medial and the lateral epicondyle, and the ulnar bone, in which the hinge joint actually rotates with the ulnar bone and not with the radius. The radius is this bone that pronates around the ulnar and allows us to do this movement of pronation and supination. What tends to happen with injuries to the shoulder joint, especially in kids, is the dislocation of this bone into this ulnar fossa here. And the bone itself moves forward, and the child doesn't move the elbow joint any longer, and they actually hold their hand upright and in this position because of the amount of pain. In adults, the common things we tend to see in the very old adults is obviously osteoarthritic changes involving the elbow joint, especially in those who are accustomed to manual labor and doing a lot of work that involves the shoulder elbow joint. Commonly we see in young adults is fracture or Colles fracture of the distal end of the radius from a fall on an outstretched arm, presenting with obviously pain and swelling involving, which is the distal end of the radius, is obviously over here. Pain and swelling involving here, and inability to even move the wrist and the wrist itself. You can also be expected to get fractures involving both of these bones, and when there's a fracture, you will need to have an open reduction and internal fixation of it in order to maintain the motion of pronation and supination. The most common complaints of patients coming into our practice involving elbow joints is inflammation involving either the olecranon and bursa, which is at the back here, that gives you a prominence over the elbow joint. And you can actually hear the patient come and telling you that the back of the bone here is actually swollen. And that's mainly the bursa at the end of the distal end of the ulna. Very uncommon is it for us to get dislocation of the radio-ulnar joint. Most commonly happens in very young adults, and fractures at the distal end of the radius is one of the more common injuries involving the wrist joint. We can also get injuries involving the wrist joint that involve the scaphoid bones. There are 8 bones that actually give us the movements of the wrist, which allows us to be able to move the wrist in all angles, and base flexion, extension, abduction, adduction, and gives us the latitude of movements that we get with the wrist. But it's also the joint that tends to be affected, especially with arthritic changes. Not only those joints, the phalanges or the small joints involving the hands, and the metacarpal bones themselves tend to be involved in arthritic changes. In fact, the most commonly involved joints in the early stages of rheumatoid arthritis are the small joints of the hand. And those patients will commonly present to the physician with pain and swelling and decreased range of motions involving the joints in the early hours of the morning. And those who are accustomed to be using the wrist tremendously with excessive amount of force, and in terms of people who do washing as a living, or mechanics who tend to use and handymen who use a lot of screwdrivers, etc., they will come very early in their professional career with osteoarthritic changes involving the small joints of the hand itself, and also the small joints of the wrist itself and the hand itself. So complaints regarding the elbow, the wrist, the hand itself is a spectrum of diseases that differs from the age of the patient. But here again, in terms of the clinician, it's up to him or her to get a proper history, a proper physical examination, and to try and see if they can resolve the pain without having an MRI. If you're unable to get the results by a blood test, whether it be rheumatoid arthritic changes or then it's probably in the interest of the patient to get an MRI to see if there's any evidence of any occult fractures that could be there that does not show up on an X-ray, or any evidence of any ligament or cartilage changes that suggest a degenerative disease. Another common presenting complaint in family practice and internal medicine and orthopedic practice is, doctor, I'm having a pain in my foot. Here again, it's which part of the foot is the first question. When we look at the anatomy of the skeleton of the feet itself and the ankle joint, we're faced with the tibia, the fibula, that articulates with the calcaneus bone itself here. And then you have evidence of the cuboid bones, the smaller metatarsal bones, the small tarsal bones, and then the metatarsal bones. The bigger one being the navicular bone and the other cuneiform bones itself. This is looking at it from a lateral section involving our skeleton. This is the distal end of the main bone, the tibia, the shin bone. This is the shin bone for us. The fibula, which is a strut bone which doesn't articulate with the ankle joint itself, and basically the small bones of the feet themselves. One of the most common presenting complaint of patients is basically, doctor, I'm having pain on the sole of the foot. And it usually involves this bone in which spurs develop, because this is one of the major weight bearing, the calcaneus, the distal end of it, of the calcaneal bone, or the heel itself, is where the spurs are formed. But it's extremely small spurs to cause that amount of pain. One of the commonly complaining things as well is the plantar fasciitis, in which the plantar fascia that supports the arch of the foot that allows us not to have a flat foot. The arch of the foot is essential for us. If you see it in the diagram, the arch of the foot is essential for us to maintain our dexterity of motion in the feet itself, that allows us to be able to up and walk and jump and make all sorts of movements. If we were to have a flat foot, this becomes much more difficult. But it's the same movement that gives us the same plantar fasciitis, that because the plantar fascia is inserted here, that can be extremely painful as well. So in addition to that, two of the most commonly presenting complaint to a physician is basically, doctor, I've got pain involving the heel itself, and that's mainly due to a calcaneal spur. In the athlete who presents to you with basically inability to actually tiptoe any longer after making a very good serve in a tennis game, usually what it involves is a rupture of the Achilles tendon. If it's a total rupture, then it needs to have surgery in which the distal end of the gastrocnemius muscle is reinserted or pinned to this portion of the calcaneus, and obviously we all know this as being Achilles tendon. The other common complaints that we find in family practice as well is basically because of the fact of wearing shoes and spending long hours, we sometimes alter the curvature of our feet itself, and in the prominent areas we develop calluses. Sometimes these calluses, or corns as we sometimes call them, basically can become very painful. Sometimes they become infected. We're infected with fungus as well, and they cause an ingrowing fungal infection into the joint itself. In addition to the young athletes who over-exercise in terms of long distance running, can sometimes sustain a march fracture, which is a fracture involving the distal end of the metatarsal bone. That's very common in soldiers who do long hours of walking, and you find that they have complaint of pain involving this portion, the frontal portion of the foot itself, under the toes, and when lo and behold, when you do an X-ray, you can find evidence of a callus being formed there because of a simple fact they had a march fracture that was undiagnosed. Usually injuries to the feet, because of a simple fact we need our feet to stand on, to move around, are definitely, even if they are the most minimal symptoms, do cause a severe amount of discomfort for the patient. And at all times, addressing injuries or complaints about the foot is to have a sound knowledge of the anatomy of the foot and some of the more common presenting complaints that patients have. A lot of times we ask patients to rest and be off their feet, but sometimes that's impossible in an economic downturn that we presently have. Patients have to walk, get around, get to their jobs, and obviously all of us are in a position wanting to keep our jobs, so at least we can maintain ourselves for better times. And sometimes we find ourselves probably injecting those patients much earlier now because they cannot afford to rest. Liberal amounts of analgesics, resting it, warm soaks, using the right footwear sometimes help tremendously. But at all times, it's extremely important. The best time to treat most foot injuries are early when they start to when the patient starts to complain of those symptoms, and not to wait until it's too late when you have to immobilize the joint and probably put the patient on long-term bed rest in order to assist in the healing process. Injuries to the wrist and the hands are also very common complaints that are brought to a family practice office. And it's good to understand the anatomy of the hand and maybe some understanding also not only of the anatomy of the hand itself, but also not only of the bony structures, but also of the muscles, the ligaments, the nerves that actually keep the hand in such a functional position that when it was left to engineers and scientists to devise a motion, even one motion of the hand, it took them almost the amount of neuronal input. Probably it makes us fathom to think how much it is that went into the formation of a hand that basically we take for granted, because there's so many motions that are connected with grasping when it concerns with the movement of the hands in all the joints involved, that sometimes it is a miraculous organ system to have when we look at it. When we look at the bones of the hand, obviously with the distal end of the radius and the ulnar forming the portion of the joint of the wrist, with the 8 bones, the scaphoid being the one most commonly fractured, which is the proximal distal end of the radius, which is easily fractured and a Colles fracture, and the scaphoid bone, which is beneath it. So one of the most commonly affected common complaints of a patient who's just fell on an outstretched hand is a pain involving this area here, which is the distal end of the radius, and also the scaphoid bone. And these are the 2 most commonly bones that are fractured in falls on outstretched arm, which is the most common injury to the wrist joint itself. We look at the bones itself. That's the scaphoid bone that can undergo fracture. This is the distal end of the radius, which you can have a transverse fracture through the growth plate, especially commonly in children, but also in adults, young adults as well. The other small bones of the hand that can undergo arthritic changes, and then the metacarpal bones, which can also be fractured with Boxer's fracture, and you get a fracture involving the distal end of the metacarpal bones. The phalanges are obviously for the thumb 2 phalanges, and the rest of the joints with 3 phalanges each. Obviously those are the ones most commonly affected with arthritic changes, and these are the ones that undergo deformity. But the movements of the fingers in terms of flexion and extension are carried out by these flexor ligaments, the flexor tendons, which cause this portion of the distal end of the index finger to flex like that, or the middle phalanx of it, or the proximal phalanx of it, all carried out by the flexor tendons. The extensor tendons obviously making this motion possible. But it's so very easy to rupture these tendons and get an avulsion injury, and you're unable to actually carry out the flexion or the extension motion, and it results in a deformity of the finger. This I found out the hard way as well. It's also in addition to that, when these tendons actually are inserted from the muscles of the forearm, that when you decide to grasp something, the muscles themselves contract and the extensor tendon work, or the flexor tendon works, depending on what's happening. Some of the more common injuries involving the hand itself is when we develop something called like a trigger finger, when the finger just sticks like this. It's a tenosynovitis, or inflammation involving the flexor tendon and the flexor tendon sheath, which is stuck together. Sometimes we inject it with a steroid and lidocaine and can have a release of the tendon. If that doesn't work, then we're definitely going to need to have an open surgery and release the tendon so it allows the motion of that finger in the flexor tendon sheath to be able to move in the manner it was moving before. You can also get something called Dupuytren's contracture, in which the palmar aponeurosis, which actually is the palmar that radiates, that gives it's a palmar aponeurosis that gives ligaments to the joints itself, can undergo thickening itself. We all know and have relatives who've had carpal tunnel syndrome, which involves numbness over the portion of the hand, the ventrum of the hand, and the tips of the finger, but not involving the little finger. And the numbness is due to compression of the median nerve as it passes through the flexor retinaculum. If it becomes an injury, that is very, very common in terms of family practice, where the patient presents said, I wake up in the morning, the fingers are all numb, I'm unable to grasp as much as I used to be grasping before, I can't type as well as I can be. It's one of the more common injuries involved in the working place, and sometimes we try to put a splint on it, put a patient sometimes on a diuretic, sometimes help, or ask them to rest it as much as they can. If that doesn't work, what you need to do is to release the median nerve as it passes under the flexor retinaculum, and that will give about significant relief of the symptoms. But understanding that injuries to the hands are very common, and because of the usefulness of the hand and the dexterity of motion that the hand has, it's sometimes difficult to overstate that we all need to have functional hands at all times. And in the event of any injuries to the hand, it needs to be treated promptly.